I'd like to acknowledge the Taranata Panir, Paninahur and Lita Myrena clans of the Stony Creek Nation on whose land this podcast is made. I recognise Tasmanian Aboriginal people as the original owners of this island who have cared for this country for over 60,000 years, and pay my respects to elders past and present. Sovereignty was never ceded, and I'm grateful to live, work and play on this beautiful country. Hello and welcome to the podcast From Experience, the Grief Collection. I'm your host, Bianca Welsh, a mum, a lost mum, a restaurateur with a behavioural science degree and a proclivity for all things trauma, grief and mental illness. So, why would I do a grief podcast? Grief is the one certainty in life, the one thing we will all face, the loss of someone or something that we love. As the great wordsmith that is Nick Cave wrote to a fellow griever, if we love, we grieve. That's the deal. That's the pact. End quote. Yet we rarely talk about it. We're never prepared for it, but perhaps we can never be prepared for it. I wasn't, but I hope that hearing other people's stories might make the dark depths feel a little less lonely and the healing journey a little less daunting. I'm curious what's brought you here today. Comfort, ideas and resources on ways to grieve and heal. Maybe you're trying to understand a loved one going through something similar. Whatever it is, I'm glad you're here. I hope that after listening to our guest today, you'll feel a fraction lighter, you might feel seen, or simply comforted that you're not alone. Please note this episode discusses hospice care, palliative care, death and dying. If this is too much for you today, perhaps come back another time. Supports and resources are listed in the show notes.
Peter is a palliative care nurse currently working as part of a consulting team in a public tertiary hospital. Before nursing, Peter was variously a hardware retailer, photo lab manager, forklift driver, apprentice electrician, driller's offsider, petrol pumper, amongst other things. He's been a nurse for 17 years, initially in various roles, before eventually finding his way to palliative care. And as soon as he started doing this work, he knew he'd found his place. He worked in inpatient palliative care hospice for 4 years before starting his current position 7 years ago. Welcome, Peter.
Thanks for having me.
Thank you. So, Peter, tell me a little bit about what drew you to nursing after all those incredibly various roles.
At high school, I had a lot of fun. It was really good. I went to a school a fair way away from home and made a lot of friends and learnt how to get around the city on my own and all that sort of stuff. And I'd always had the report card saying would do really well if he applied himself sort of thing. But I just never applied myself. I did a little. There were things I liked, but yeah, I just didn't do. I was considering being a viticulturalist for a bit while I was at high school because that was the lowest entry score into uni you needed. And I didn't even get that. Like, I graduated, I passed everything, but I didn't get enough of a score to get into university, which seemed to be the thing to do. And I just got a job after finishing school. But while I was at school, I made a lot of good friends. And one of my best mates, his mum was a nurse midwife, and she was just one of the coolest people I knew. And we're still friends. We're pretty good friends. I'm visiting her in a few weeks. And I remember being 15 thinking, oh, yeah, no, maybe I could. I like doing human biology at school. That's cool. Maybe I could do that. So that was the first time I ever thought of it, amongst lots of other things. And I didn't really think about it again until I'd been wandering around doing all these different jobs. And I took this apprenticeship on a mine in WA just because I wanted to do something that was long-term good, and I just didn't enjoy it. All my friends were in Melbourne. They'd moved there. Being from Perth, a lot of people were moving to Melbourne. You'd resent that. You'd be like, oh, come on, don't move to Melbourne. Why do you want to do that? And then I was in the Kimberley and working on this mine, and they were all having a good time in Melbourne. I was like, okay, I'll come and visit. And I visited, and I'd never drunk alcohol in my life. I was 25.
Wow, but you were thinking about becoming a viticulturist.
Yeah. There's an irony there. It's a good lifestyle, viticulture. Anyway, I got there and I'm like, my friends are like, you're so stuck up, you can do whatever you want, you can be whoever you want to be. And I was like, okay, you don't have to be this guy that doesn't drink if you don't want to. And it doesn't mean you have to go hit it. So, yeah, I just had a beer once and then a wild turkey and Coke. And then I was going out every night, driving forklifts in Melbourne. And then I met this girl. And yeah, it was just like magic. And she was a medical student, and it was just this really rapid falling in love thing. It's like, oh, maybe I could, that's cool what you're doing. And I just thought about doing nursing again and started uni. And as soon as I started it was good. It was this hands-on stuff where you can look after people. It was hard to learn a lot of the stuff. And it was hard getting through uni. Like I'm still no good at it. I do postgrad study now, and still I'm doing the assignments last minute. But I get them done and I get good marks. So we graduated and moved to Darwin, and I did all sorts of nursing roles there. And it was great. It's been a great career for me. I often think, people ask me, they say, I'm thinking of doing nursing. And I'm always like, are you sure about that? Like, really? It's pretty full on. And we talk about it in detail if they're really interested. But as soon as someone says to me, I've started studying nursing, I'm like, yes, that is so cool. I'm so excited for you and I'm proud of you and I can't wait to see what happens. And then you see them around the hospital or whatever. There's this acknowledgement of this experience that you've shared now that you wouldn't understand unless you've done it. It's a cool bond that nurses have with each other.
That's cool. I think of that like with kids. If people are thinking about having children and they're like, it's really like a very democratic, diplomatic kind of neutral position. And then when they do have kids, you're like, oh, thank God they're going to know. They're going to know how tough this is.
Well, and they'll also know the good bits,
Exactly.
When I wasn't doing palliative nursing, I always was attracted to these wards where they weren't specific, they weren't surgical wards, they were medical wards really, but they're like the bottom of the heap. So when people have lots of different illnesses, nothing necessarily specific, stuck in hospital for a long time, it's really hard work. But I always feel comfortable in those wards because the nursing staff there are good. They care. And that's not to say that other nurses don't care, but there's something about those shit fight nursing wards that are cool. and you look at them and objectively it's a terrible job, but there are these things about it that make you feel fulfilled and it's cool work, I reckon.
So what then led you to palliative care nursing?
Well, I'd done a lot of nursing roles in Darwin and then mostly those medical wards, and then I moved to Melbourne for my wife's training and I was in the nurse pool working all over the place. I was just doing all these different things and never really settling and focusing. And I had to figure something out whether to keep nursing or not. And I hadn't done palliative nursing before, but I'd done some in the nurse pool and it looked pretty good. And then I just went to the nurse unit manager. There was a ward at the hospital I was working at that had haematology, oncology on one side and then these 10 palliative care beds. And I asked him if I could work there and he's like, yeah, that's cool. Come on the next roster and see if you like it. And just as soon as I started and just the focus of the care is what I sort of think nursing should be anyway, in a way, and it is to an extent, to some point, but I think it should be more so where you're just focusing on what's important to the person. And I was a bit confronted by the conversations and being able to talk about it, but I could tell that how meaningful it was when it was done well, and it just immediately felt good to me. So pretty quickly did some postgrad study and then only worked in that unit, and then we moved here and I've been in this role. So I work only in the hospital. All my colleagues work in the community. I've never done that, but there's other nurses on my team. We go to the hospital, we see people who are new referrals or we see people who are known from the community that come into hospital and we try and make things as good as they can be for them.
Peter, do you think it takes a certain person to be able to work in the space that you do?
Yeah, it does. And I think about this when someone says, because often people say to me, I don't know how you do that. How can you do it? And I'm like, well, and my first thought is, and I don't know if this is fair or not, but I'm like, well, I'm not a cop. I couldn't be a police officer. And there's people that can. I couldn't do all sorts of jobs and there's other people that can, and I can do this one. You sort of settle into it and you have to want to do it. Like the biggest tell for someone who's going to be good at palliative care is someone who's interested, someone who asks and says, look, I'm interested in this and I'd like to try and do it. If you're saying that, then you've thought about it and you're probably going to be a good fit. But if you're rotating through as a grad or if you're reluctant to do it, it's not going to work.
What do you think it is that makes us so scared to talk about death and to be around it? As you said, a new nursing student or something, going into the field would just be too confronted by it?
Yeah, often. Often it's a scary thing, but people want to do it. Like I come across a lot of nurses who really want to be good at it but don't have the experience, and they'll ask questions about how to talk to someone. And you've talked on the podcast before about it's better to say something than not. And I always encourage people to show vulnerability when they're talking, even if they're a professional, a clinical professional, just to demonstrate that it is a difficult thing to talk about. I focus a lot on human interaction stuff. It is human to feel these things, and if you're trying to hide them, then it's not really helpful. But culturally, we're not, in Australia, we're not that good at talking about dying, obviously. And that's one of the reasons I'm here, is because I'd love that to be a bit better. And I've often thought, how can we change society to be better at dealing with these things? And this is the sort of thing that can help. But culturally, it's difficult, and I don't really know why. I think historically, there's all sorts of reasons. Historically, it was a bit easier. It was more obvious when people were dying, and but even then, like in the 50s or something, 60s, people would die and people wouldn't talk about it. There was a lot of taboos. People talk about more things now, and there's a huge cohort of people that love talking about dying and they really want it to change. But yeah, most of the time we come across people that haven't really given it too much thought, and they don't have the language to talk about it, and they see it as a failure, and they think, well, I know it's going to happen to me, but when it's happening to me, it freaks me out. I just can't deal with it. It'd be good to encourage people to have the language to talk about it.
Anticipatory grief is something that I'm really fascinated by, and hence why I've asked you on today, and our great conversation that we've had at a recent birthday party and since. And it just really fascinates me, human behaviour. Obviously, it's what I do. Is there a general sort of camp of people, I'm kind of generalising and stereotyping, the certain ways people respond when a loved one is dying? Is there the denial? I mean, I'm just assuming all these things. Is there sort of a denial camp? Is there then the almost refusing to believe that it's happening camp?
There's all sorts of ways people respond to dying. You can tell when someone's given it some thought and they're pretty reconciled to it. And you can tell when there's grappling with that. And then there's this approach that I remember coming across pretty early on in palliative care that I was really confronted by. I'll tell you the story. So there's a young person with a terrible sarcoma in his leg, and it had metastasised and he was going to die. When I first met him, he wasn't that sick, but then he came in and he was obviously not going to go home. He's probably going to die during that admission, but he wasn't that unwell. Like you could talk to him, and he had day-to-day stuff that he was doing, and he was clearly not accepting he was going to die. And I was like this new palliative care nurse, and I'm like, right, we got to sort this out. You need to understand this, that this is what's happening, and you need to accept it. And it wasn't brutal or anything, but I just felt it was my job to go in there and try and help him reconcile with what was happening. And I remember talking to him gently one day, and he said to me, he looked me in the eye and he said, Peter, look, I know what's going to happen. I know it's happening, but I don't want to talk about it. So stop talking about it and let's just live day to day. And I was quite floored, and I've reflected on it a lot since. It wasn't appropriate of me to go in there thinking I knew better than him, and it made me realise that it is an acceptable way to deal with what he was facing, and I'm much better at recognising that now.
That's interesting.
Yeah. So I come across it all the time, all the different approaches to realising you're going to die, and that's one of them. And still you see people saying, he doesn't understand or she doesn't get it. And I'm like, yeah, but maybe that's okay, because if you bash them over the head with it, if you go in there every day and you say, look, you're going to die, man. Like, come on. That's not a life. And for that person, it's much better just to roll with it, I think. It's much less distressing for the person. And the whole point of what we try and do is to relieve distress.
It must, though, be a very fine line and a practice thing for a very special person like yourself to know when to take the lead, though, because I'm sure there are people and circumstances where they just need a little bit of coaxing to be able to, and then the flood balls open and they are better for it.
Yep. So the job I see as the focus is relieving distress, and distress can be, I don't know what's going to happen. I'm really scared. And you can talk about that and you can work your way through that. And if someone doesn't want to talk about it, and one of the things we always do is to ask permission to talk. What sort of, how deep should we go into this? Is it okay to talk frankly? I say that a lot. And almost all the time people are like, yes, do it, please. Because so far people just generally haven't, and we don't really get it. But sometimes you can pick up when they don't want to do that, and so you just don't. But when they do, you do it gently and you ask questions. And one of my approaches is to say, this is my understanding of what's going on. You tell me if I'm missing something, and sort of paint a picture of the reality of the situation, then say, well, what should we do now? What do you think the best thing to do is? And that's a good way to do it, I think.
What is it like to be an observer of death? I'm assuming you've been in the room quite a few times throughout your nursing career.
Not so much these days. I remember it happened a few weeks ago for the first time in a while, because usually, my job, we go see someone, we set everything up, and then we come back the next day. We're only there for half hour or so each day. But I used to be there all the time for that sort of thing. I think it's a special thing. Like it's not something you get like many people see. And you feel quite vulnerable because you feel like if you do the wrong thing, it can cause harm. But really it's not that. You feel like that, but really if you're human and you're there and you're understanding what's going on and you can talk in gentle ways, then it's not too bad. The main thing is we'll say, look, I think the person's died. We'll just check a couple of things. There's no hurry to do anything, and just don't rush out of the room, that sort of thing. Stay in the room, and you can inquire if people have any questions or that sort of thing, and we'll go out and give them some time, and then we'll come back and we'll go through a bit of a procedure to confirm the person's died, and then talk to them about, we can give them a wash now and present them nicely and that sort of thing. And sometimes people help with that and sometimes people don't. And what I try and say is that there's no hurry to do anything, because there can be this, people are like, what do we do now? The main message is don't hurry, spend some time, and then the practical things like when you're ready, we'll take them to the mortuary and you can work with the funeral director from there, that sort of thing.
Is a lot of your role, or a lot of your team's role, in educating what the family are to expect in the lead up and then post? Yep.
Yeah. I got to just immediately, there was a few tangents that burst in my mind then. One is on the anticipatory grief thing, and one is on some people in palliative care, reputationally, people think that we only see people who are dying, like actually dying. But most of the people we meet initially, they're not dying. They have a disease they're probably going to die from. And they might still be receiving treatment for like palliative intent treatment to try and relieve symptoms and prolong life without too much, to find a balance with that. So in those cases, you just get to know them, you work on your relationship and you work on the symptoms. And then you try and do a bit of planning. So if this happens, what would you like to do? And you talk about what's likely to happen and how you'd respond to it. And you'd work out where the care should be. Should it be at home or in the hospital or in the hospice or that sort of thing? And this is what it's like in each of these places, and this is how we would approach everything. And that's really important information, because I try and focus on avoiding imagining what might happen. So I imagine someone who's not aware of how this stuff might work, what they're imagining, what they're thinking dying might be like, or what they're thinking looking after someone at home might be like. And I say that to them, like, it's better that you know this rather than you're imagining it and getting it wrong. So this is what it would be like. So, yeah, that's an important part of it. And it's the same if someone is dying, and we're talking about the dying part of life. Yeah, we talk about what to expect, how someone might become confused if their organs aren't working and their blood gets a bit toxic and their brain can't function all that well. They'll have difficulty making sense of what's going on around them. This is how we'll respond to that. This is how we'll treat it. People expect to have pain when they're dying, but often people don't. It's not a given. But if they do, this is how we would respond to it, and that sort of thing. We talk about breathing changes. That's a big one in terminal phase. So terminal phase is a clinical term, but that's what we'd call it. So, when someone's unconscious and they're dying, they're unable to clear the secretions in their throat, and you can hear the breathing through it. And before someone gets to that stage, and not everyone does, we say this could happen. And if it does, for that particular problem, the person is not aware of it. They can't be aware of it. If they were, they'd be able to clear it. And we can do things to try and mitigate it a bit, but they're not super effective sometimes. But if you have that conversation before it happens with a family, it's much better than if you don't and then it starts happening and then you have to explain it.
I can only imagine how traumatic that would be for many people that aren't prepared for that. And do you think that movies and media have absolutely ruined us in the way we think people die?
Well, I don't know about ruined, but they're inaccurate mostly, yeah. I always think of $1 Million Baby with, what's her name? I can't remember her name, but she's got a trachea in, so it's going down her throat for her breathing in the ICU or whatever it is, and she's talking, and you can't do that. Like that's the tube's going down through your larynx. You can't talk. So yeah, they get it wrong all the time. And even if they got it right, when it's you and you're there, it's different. You can know that it's coming and still be completely floored by it when it happens. Yeah, that happens all the time.
Peter, have you found along your journey a medical professional, whether that be a doctor, a social worker, another nurse, make things better and make things worse? I mean, in my journey with our son Herbert, there were certainly things along the way that some people made so much better in terms, an awful situation slightly more, I don't know, tolerable, and then others made it absolutely horrendous. What are some examples that you've seen?
A few come to mind. Doctors and nurses are diverse. They come from all different backgrounds, and that's a real strength. And within nursing and in medicine or surgery, whatever, there's people who are attracted to different fields and they're focused really well on those fields and they're really good at them. But all of their patients are going to die at some point and they just don't really know how to deal with it, and they might not give accurate information, or they don't know how to talk about it, or they do and they do it really in a pretty blunt way. But it's not their skill and it's not their core skill. Some of them are really good at it, some of them aren't. Same as every job. There's people who are good and get it right, and some people who don't so much. Just a minor thing happened a while ago where someone had a scan of their brain and the doctor had noticed some normal age-related atrophy of the brain that happens to all of us, and commented on it to the patient, and the patient was so distressed by it. They didn't hear it the way it was intended. But that patient was stressed. They're really worried and they're hearing this thing, and we all know that when you're hearing bad news, you don't take it all in. You have to hear it a few times and you have to be in the right space to hear it. So it is a bit of a skill that not everyone has. You can say the wrong thing easily, but if you do, you can talk about it later as well. I've done that. I've found myself thinking I'm on the right track with something and realising I'm not later, and going back in there and saying, listen, when we were talking last, I was thinking this and maybe that didn't work out, and I'm sorry if that happened, but we can talk about it this way if you like, or we can approach it in a different way. And I think it's better to do that than you can beat yourself up a bit. You can relive things in your mind a bit, and I think you should avoid that if you can.
It's good advice. When you talk about where people are going to die, you mentioned before about whether they're in a hospital, hospice, or at home. You've mentioned in our conversations leading up to this about the dying at home conundrum. Can you talk to me a little bit about that?
Yeah, so there's good research around, or good survey research, and it makes sense. If you ask someone, if you were dying, where would you like to be? And there's a huge percentage of people, most people will say they want to die at home. And then when you look at who actually does die at home, the amount of people that do, it's not that much. It might be 20% or something like that off the top of my head. And one of the big parts of our job is we come across people who are probably going to die soon, and we have to talk about where they might want to die. And often the gut reaction is, oh, well, I want to go home. And the reality of that is really fraught, and I don't think people understand it, and we have to explain it to them. But the main problem is the resources to care for someone at home, the external resources that aren't family, just they don't really exist. You can get a nurse to come and visit maybe once a day sort of thing for half an hour or so, maybe at the most twice a day. But most of the work will be family. They can walk to the toilet, so that's okay, I'll take them home. But then when they're dying, they're not going to be able to walk to the toilet, and they're going to become incontinent, they're going to become unconscious, and then they might have challenging symptoms, and you're going to have to deal with those. And we can set people up to do it, and people do it successfully all the time. But it takes a certain alignment of the stars for that to work for people. They have to have the right family in the house, and they have to have the right goals, and they have to have the right attitude, like the attitude of the family. There can be people who have the physical resources but not the mental capacity to do it. Like not capacity as in like cognition, but they just don't have the emotional capacity to do it. And when we're arranging these things, we always try and give people a really good opportunity and we'll say to them, look, if you're not sure about this, or if you're doing this because you feel obliged but you're really worried about not doing it, we can give it a go, that's fine. And if it doesn't work, we'll come up with an alternative. But it's better to say, I can't do it. It's really brave to say I can't do it, actually. And I'll say that to them, because you feel like you're letting someone down when you say, look, I'm not going to be able to look after this person at home. But the main problem is this expectation that you would be able to get someone home and get a lot of resources into the house to look after them dying. It's not realistic. And like I've worked in Melbourne, and there might be a few more resources in a big city, but it's still mostly family. And overnight it'll be family. I think it's a universal problem. And I don't know if it's a bad thing. I think ideally, culturally, it'd be great if we could all support our family when they're dying and support them at home. But it'll take a huge structural shift to be able to do that. I've got this bias because I haven't worked in the community. I've only worked in hospice and in the acute hospital. And hospice is great. It allows people to not be at home, but set themselves up in not a hospital setting, with people taking care of the tasks that need taking care of, and some spiritual or counselling sort of good conversation. And the family can come and be there, bring the pets in, bring the photos in and all that sort of stuff, and not worry about the tasks. I think that's a really good model. But there's never enough hospice beds either.
I think in my experience with a completely different experience of it not being a living person, I know that I was really reluctant to have the birth of Herb up here. We were, if anything, I find it fortunate that we got sent to Hobart and that everything happened down there, and I had a separation of place. I respect and I understand, I think, why people would want to die at home in the comfort and surrounded by
and it
things.
works well often for some, and it's beautiful when it works out.
But I also have that little bit for the people that are left behind, the trauma, the reminder of that, the sounds, the smells, the sights, the whole thing could be really long lasting of that memory. And I love the idea of hospice and not a hospital, because the clinical nature of hospitals can add to that.
Totally it can.
Add to the trauma, add to the grief of it all.
There's people who die in the emergency department. We were talking about this recently. One of the medical students presented this, discussed a few things, and that was one of the things about he'd seen someone dying in a resus bay in the hospital. They knew that was what's going to happen, and there was just no space anywhere else for them to be dying. It could be better, I think. That wouldn't have necessarily meant getting to a hospice. You'd need a hospice bed, and the hospice is often off-site, so you've got to transport them in an ambulance. But if you had a space somewhere that was a bit less clinical for this acute dying thing, it would be better. When we drive past the hospital where our kids were born, we're like, oh, you were born there, So it does bring thoughts, and if you have to do that every day for a traumatic thing, that would be hard. For people dying at home, it's something we talk about, and often the person who's dying, they might say, I don't want to die at home because I don't want them thinking about me there, or the family will say, look, there's this kid at home, maybe that would be really hard on them to have to know their whoever it is that's dying at home. So it's something discussed, and for some people it doesn't matter. Some people it does.
Do you find much cultural difference in the way people, in these circumstances where people know that they are dying? Have you seen different rituals or the way they talk about it?
Yeah. You can't assume based on someone's cultural background how they'll respond and how they'll approach things and how they'll be comfortable with it or not. But there's this conundrum we come across sometimes, and I probably came across it more often in Melbourne than here, where family would ask you not to talk about dying to the person who's dying. And that was a difficult ethical question, and we'd have to navigate it by saying we can't withhold information, and you'd work out a balance sort of thing. But it would create tension, and some families could get quite upset if they thought that's what you were planning on doing. Inevitably, when it came about, the person had a really good understanding. They knew what was happening anyway, and they either didn't want to talk about it or they did, and they were usually quite accepting of it. So that's one cultural ethical problem. In Melbourne, a few times there was a Buddhist that had died from a monastery of some sort, or they were connected to some sort of monastery. And after they died, we weren't allowed to touch them for 12 hours, something like that. And a few times some monks would come in and chant there for 12 hours. And it was sort of cool, you'd be walking down the ward to somewhere else and you'd hear this chanting coming out of this room. And another occasion they had recordings of the chants, and on another occasion they had a live stream from another country of someone doing the chanting for this person in the room. And that was cool. I haven't seen it here, but that people do have all these different ideas about this stuff.
It's really interesting growing up and watching American movies and seeing either in a comical way or in a serious way they've had open caskets. And I always thought, gosh, that would be so confronting and that's terrifying, like to see a dead body. But in your experience through this role, do you see it a really important part for families to come and see the person?
Yeah, it's a personal thing, and I talk about that with people. They might say things like, I don't want to leave them, or often it's uncanny sometimes people have a vigil at the bedside and then they leave for whatever reason, the room's empty and the person dies, and they'll want to come back and see the person and be with the person. I think for kids it can be helpful sometimes. It depends, and it's a personal thing. Some people just want a phone call after the person's died. They don't need to see them dead. I remember the first time I saw my grandfather, he had an open casket. And that was the first time I saw a dead person. And I was nervous and scared to see it, but I think it was good to see because it's so real. It really makes you realise, you can cement it in your mind what's happened. And it's normal.
Yeah, and I guess that's why we have these conversations and how bad we are in the Western world. I remember when I was a child, actually, I'd forgotten this. My parents took me to Vietnam and we went and saw
Ho Chi Minh.
Yeah. And you just walk in silence. You're in the room for, I don't know, not even a minute. You walk around this walkway and he's dimly lit and perfectly preserved and you leave. And I remember going, it was really strange to go and see a dead person and how many people. There were hundreds of people there on no particular special day to go and see that. It's interesting.
I don't know if this is the right train of thought, but it makes me think about a famous person. I remember seeing Nicolas Cage in Melbourne. I'm like, that's Nicolas Cage. He's real and he's there, and it makes it real. So when you see someone that's been a part of your life and they're real and they're there and they're dead, it just makes it real, I guess. Yeah, and I think it's helpful. But some people don't want to do it, and that's fine.
Peter, your understanding and your acceptance of death and dying, how has that changed for you over having this role?
I've got a bit of a reputation for when I meet new people, we always end up talking about dying. I don't know if that's a good thing or not, but people are interested, when they say, what do you do? And I tell them what I do, and they're like, oh, wow, how do you do that? That sounds terrible or sounds like interesting or whatever. We inevitably talk about it. I remember when I started, I told you that story about the guy who didn't want to talk about dying. And so I've had to put a lot of work into the language, developing language and working out the important bits and the not important bits. And I see it in people who are interested in being able to do this when they're just starting out trying to develop this stuff, that it does take time. And I think when you are working on that, you can't not reflect on your own life and your own death. There was a brief problem where I found myself imagining that everyone I knew was going to die in the way I see people die with a cancer or some sort of, heaps of people die that aren't involved in palliative care and probably don't need it. And I had to really work on that for a little while. I went and saw someone to talk about it, and it wasn't helpful really, but it helped me reflect and work through it myself and just realize, like I had to hear about people with cancers and hematological diseases recovering and surviving and going, oh, this happens a lot. There's heaps of us around everywhere that have been through this and survived. And so those sorts of things helped me. But I worry a little about how I would be if someone I loved would be a patient of ours, or if it was me, how I'm going to respond. I like to think I'd be cool as ice, and I worry a little about if I had a cancer, my gut instinct might be to not have any treatment for it or investigations. I worry a little that I might do that. I don't think I would. But what we always encourage people to do is, that's fine. I understand that's your gut reaction. Just have a chat with these people who are offering these treatments and then make a decision. Because a lot of the time you can see people do really well with these treatments, even if they're palliative intent, and they're not difficult to go through, and they can make your quality of life better. And so I worry about freaking out a bit. I'm going to tell you the story I didn't tell you before, but I'll de-identify it a little, okay? So I know this person who I really respect as a palliative care working person, and they taught me a lot, and I was talking to a colleague about them, and the colleague said when that person's loved one was dying, that person came in to the hospice and was feeding the person when they were unconscious. And they were clearly absolutely, they were super distressed because that's not normal. And they would have known so much more than a lot of people. And I think about that a lot. And I think about, will I be like that? Or will I be able to hold it together and not panic and fall apart?
So with all good intentions, what you're saying basically is that we can't prepare, and we just have to accept the way we respond, we actually don't really have much control over.
Yeah. In a way, I guess. But the main thing that I think is helpful is language, and just being able to talk about it. If you can't talk about it and you don't have the language to talk about it, or you're hearing stuff in too complex ways to decipher yourself, then it just leads to distress. You can prepare, and you should, because if you don't, it'll be worse. But your preparation will inevitably not be perfect.
And can you articulate what some of the language is that you've had to add to your vocabulary and how you do talk about it better?
Yeah. So one of the main things, I use normal a lot. I use distress rather than, I used to say things like agitation, or sometimes might throw it in there but not focus on it. Some of the medications that we use I used to describe as sedating, and that can be a bit difficult to interpret sometimes, so we just say calming because that's the intention. So I focus on normal a lot and try and keep it really simple and not too technical, and avoiding euphemisms is a big one. It happens all the time. You deal with these highly skilled doctors who can't say dying or
Wow.
or death or whatever. It's not that they can't, it's just that they avoid it. And when they say it, they feel like they're saying something really harsh. And so they'll say passing away and all that sort of stuff. Or like we might have a report about going through a list of people who have died and they're, oh, yeah, passed that night or whatever. Those euphemisms I understand and they're common in our culture. But to me, what it says is that the doctor isn't comfortable with discussing dying, that it's a taboo and that it should be avoided if you can. And it makes it a less tangible reality. If there's an opportunity, we'll try and have a discussion with anyone. I'll have that discussion with anyone if they're using the euphemisms around dying to try and encourage them to use the words dead, dying, death.
Wow, I find that really fascinating that you've got doctors that struggle to say the word. When we were going through Herbert, we asked some people in the profession, how do we explain this to our son Claude? So Claude was 5.5 and they were really clear and firm that you must say and use the word death and dying. You have to say that he's died, because if you say he's sleeping, he went to heaven, he went to the clouds, you you use those euphemisms, then they might get scared themselves to go to sleep. They might have a completely what a child's brain, where it can go, you don't know. So you have to be really
and it sounds like an abnormal thing. It sounds like you're avoiding talking about it and you can't talk about it. And yeah, it's just avoidance of reality and normality. Even when I'm meeting someone who's well and I'm just telling them about how we operate as a service, when I'm talking about the hospice, I'll talk about how, because a lot of people associate the hospice only with dying, and it's not like it's a good place to die, but they also look after people who have complicated symptoms that can't be at home. So they might come in from home. We work on the symptoms in the hospice and they go home again, and that's common. So I would say that to someone. And then the other reason for admission there is if you might be dying, then that's a really good place to do that if home's not working or hospital doesn't suit or whatever. So a way to get the word in there that we're here to talk about that if you want to talk about it.
In terms of for you experiencing people around you dying over the years, what sort of epiphanies or what has your understanding been when you're maybe at a friend or family's funeral yourself? What's that been like now with the perspective you've got?
My experiences with dying are probably pretty common, like personal experiences. My grandmother died at home suddenly when I was about 15, and that was the first person I know who had died. I had a friend at school who died from leukemia just at the end of school, and another friend who had a similar disease that survived, and that was really difficult for everyone. But I remember when I was in Melbourne, I just moved to Melbourne, fallen in love, and my now wife's, one of her really close friends died, and we went to his funeral, and heaps of people were there, like 300 people or something. And you know that Peter, Bjorn and Mary song, that whistling song? There was this really somber part of the funeral, and then that came on and everyone laughed, and it was all really nice. And then they took his body out and they put it in the hearse, and the hearse was driving away, and I just lost it. Like I just fell apart then. And it was to do with, we were talking earlier about bodies and dead people and famous people, just the reality of the person being there. And they were taking him away in the car, and I was like, we're never going to see him again. That's it. Like this, I knew we've just been through this funeral. I know he's died. But when he was driving away, there was something that happened inside me. And when I was growing up, I'd gone to these Christian camps and stuff, and culturally was Christian, but it wasn't really for me in the end. But I hadn't really formed this global understanding of how we work as a society, or how to view it, And when he was being driven away, my understanding of the world fell apart a fair bit. I had to reconstruct it. And the reconstruction, there were 300 people there, and they were beautiful. And we all felt these things. And I was like, this is it. We're humans, we're animals, we have feelings, we're diverse, we have different approaches to things, different understandings of things, different educations, different abilities to process information around dying. And yeah, that's been my approach since. We're people. The value we get out of being alive is interactions with other people. And if we can get along and we can help other people in difficult times, and that's how I've been able to restructure things.
And that's definitely how you live your life.
I hope so.
Peter, what would you like people to know about dying?
So that is normal. That's the first thought, yeah. It's going to happen, and it can happen in all sorts of ways. When I ask people, it might be when I first meet them, I'll say something like, our role is to help manage your symptoms, but also we want to plan for the future if we can. So if we can talk about it, that'd be good. And they might say something like, it's okay, I've already got my funeral planned and I know what songs I'm going to play and all this sort of stuff. And that's cool. That's a great thing to have been through because it's made you think about it a bit. But the bit I'm interested in most is the bit before that and the bit in the weeks before that or months before that. And yeah, I just want to be able to talk to people about it, I think. I think that's the main thing. If you can be confronted by this idea that you might die from something, and that's hard to work through, but if you can be open enough to discuss it with someone and plan for what you might want and have a really good think about, if this happens, how should we respond? Where should we be aiming for looking after you? What are we going to do if that doesn't work? I talk about normal a lot, but the other word I'm using a lot more is tension and trying to relieve tension. So if there's a tense question about this happen. So this is an example. There might be a person who is wondering whether to continue with some sort of treatment or the treatment being offered might be helpful. And I want to be really conscious here about saying that and I've said it already, a lot of people's gut reaction is I don't want to have chemotherapy or I don't want to have treatment for whatever this is. You can tell I'm focusing a lot on cancer because a lot of the people we see have cancer. But I try and encourage people to listen to the oncologist and don't feel like they have to not have it or whatever, or that it's going to be terrible. I don't want to have a reputation as someone who discourages someone from having these treatments because I think maybe there might be a few people that think that we do that in palliative care and we don't. But we respect people's decisions based on whatever they want to do. But yeah, there might be someone who's facing this situation where they might have a treatment option or they might not have the treatment and know that they're going to deteriorate and die. And we would try and give them an idea of how that would be managed and what it might be like. And it's tense. And once the decision is made to do either, it relieves a bit of tension. If the decision is to have treatment, there's still a little bit of tension, but not too much. But you can see these things that happen sometimes when someone goes, look, no, let's not do that. Let's just forget about treating it, accept that I'm going to die from it and live day by day. And this tension releases. And it's really nice to see that happen sometimes. The other time it happens is when there's this question about going home for dying or going to hospice, or when you just don't know what to do because it's a mess. Let's just get you to the hospice. There's a bed. We'll get you there and we'll just see what happens. And as soon as someone gets there, this tension's released and everyone relaxes a bit. They've got a bit of time. The care needs are met. So relieving tension is a good thing to focus on.
So it's almost not looking too far into the future. It's accepting that you are dying, but it's also actually not just focusing on that you are going to die. It's about what's happening here and now and how can you make that as less stressful and as less tense as possible and whatever
as human
that
as
is.
possible. Yeah. So interacting as a person, going, trying to understand the issues, where the tension is and relieving the tension. So someone might be worried about eating and drinking. And here's an example of some language. So someone's family or the person themselves might say, look, I'm not really eating much. I just don't feel like it. And the summary would be, that's fine. It's totally understandable. You've lost your appetite. And our advice is always eat what you feel like. And if you don't feel like it, that's fine. And the extension of it would be, if you tried to intervene, if you tried to do something to increase nutritional intake or meet structured nutritional goals for the day, you would cause a lot of distress. You'd have to be drinking these really nutrient-rich drinks, or you'd have to put a tube in, or you'd have to hook someone up to something, and you're not going to achieve it, and you're just going to create distress, discomfort, nausea. You're going to risk aspiration, and it's not worth it. There's an example of language and how talking about it in that way can relieve that tension. I've seen families really worried about nutrition. You've got to eat. You're going to die if you don't eat. Well, they're dying anyway, and we're adding to distress by intervening in this way. Generally, I think that's a really important, that's one little example.
It's very person-centred, isn't it, care? It's just focusing, and what you said before right at the start is that's what nursing should be about. Is at the core is that it's just centred on the person rather than it being a script or an expectation of what others want for the person. It's just what the person can cope with.
Yeah, and in this job it allows you to do that. And I did say it should be what we all do. And like GPs are really good at it, at focusing on the person. And a lot of people are, a lot of clinicians are, but I understand if you're in a surgical ward and you've got a thing to fix and your workload is huge, then it's okay to just get through the job, and you have to have a bit of holistic context, of course, but I can understand why it happens. Yeah. And the other bits can be picked up later.
Is there anything you know now about dying and death that you wish you knew at the start of the palliative care journey?
I wish I knew what I know now, and I wish everyone did, but it takes time and effort. And I have these conversations with my family now. Like my mum, she's done an advanced care directive, and I know what she wants from those things, and they're really, really important, valuable conversations. The fact that you're doing that to start with is enough. Just to say, look, it doesn't have to be morbid necessarily. It just has to be. You're saying, you're acknowledging, at some point this could happen to me. I will die somehow, but it could be straightforward, no problem. But it could be complicated, and if it is complicated, this is how I'd like it to be managed. If we're having those conversations with each other, it becomes culturally normal to do it more openly with everyone else.
In terms of the way you see people, I know you don't see a lot of the post, the grieving after.
Yeah, I've told you that you talked to me about coming on this, and I was like, I'm not a grief specialist. I don't feel that I've done some training in grief, but the main thing I know is just to not ignore what's happened, to acknowledge it, and to have empathy. But I don't know, I've got no techniques or anything, and I don't feel that comfortable. Like, I feel a bit out of my depth. I can walk into a room with, 20 people in it and a dying person and be really comfortable, but I can't, like, talking to someone afterwards. I feel like I can do it, but it's certainly not a specialty of mine.
I think you underestimate yourself. But I think it's, in what I've learnt, I think in my short time, is that grief is all-encompassing. It's the before, it's the lead up, it's the moment, and then it's the post. And you're very experienced in the anticipation and in the lead up. I think that's a really important part of the whole spectrum of grief.
That nutritional thing, the conundrum, is part of anticipatory grief in a way. Like, if families are worried about that and you don't talk about it, or if you don't talk about the secretions, the death rattle thing, or if you can see one person in the family is really stuck on what they perceive as a misdiagnosis or a missed opportunity or something like that, or there's all sorts of scenarios. There have been situations where a person has wanted to use VAD but hasn't made it through the process before they died, and people can get really distressed that they didn't make it through or whatever. Being able to talk about it before it happens can be really helpful for later. It's constantly on my mind when I'm talking to people, looking for signs of stewing or just worry about a situation that might not be worth worrying about.
I know voluntary assisted dying is out of your work scope and realm, but do you have feelings and thoughts around that it exists and it's now legal?
So we make a an explicit point about palliative care not being part of voluntary assisted dying. Well, no, that's not the right way to phrase it. They are the Voluntary Assisted Dying Commission. We are palliative care. We really wouldn't want people thinking that if they're accessing palliative care, we're going to convince them that voluntary assisted dying is a good thing or whatever. So we're very neutral about it, and we're very accepting of people's choices. And plenty of our patients pursue it or not. And if they're pursuing it, they don't have to tell us. Most of the time they do. I find it helpful to know. But the main thing that I talk about when I talk about it with people is that that's fine, and I support you doing that if that's what you want to do. We will still plan the same way we would anyway, just in case either it doesn't work out or you get the substance and you don't use it. And that's comforting for people, I think.
And do you find some people do get approval? And I know it's early days. It hasn't been anything
it happens
long.
often. Yeah, people get it and they don't use it.
Wow.
Yep. A big part of VAD, I think, is people having this comfort in knowing they can use it if they want to, or they have this bit of control that otherwise something they have no control over. So yeah, it's pretty common that people don't use it.
It's really fascinating.
It's common that people do use it too. And there's different ways, like you can take it yourself, and if you can't take it yourself, someone can give it to you, like a clinician. So it often has to be a little planned. But there've been situations where we haven't known someone's been pursuing it, and then they've accessed it without us really knowing. We've found out afterwards.
Wow. When people go through this, and perhaps they have been through it before with another family member that is palliative care and the person is dying, is the person at all slightly better versed or almost practiced at it? I mean, I know that when I went to seek therapy after Herb, and my therapist asked, how did your family grieve? And I was like, oh, terribly. It was just once the funeral was over, you're back to kind of normal life. Like, do you find that people that perhaps have experienced it before?
I always ask, if we don't explicitly say, have you been through something like this before with someone, but you can pick up on it sometimes. You might just get a hint that someone looked after, this is my mother and now this is my father, and I looked after my mother. And I'll always try and gently inquire, how did that go? Like, what was the experience like? And try and respond in a way that validates their experience but focuses on what we're going to try and achieve now, and acknowledging that all these plans don't always work, but we're here, we're going to work on it, we're going to work together on it. I think most of the time when I come across that, people feel well armed to deal with it the second time, I think, even if it was a bit traumatic. Maybe they're holding it together to get through this thing and I don't see the collapse afterwards. But most of the time I find people are just a bit more practical and more accepting and help more. I'm just trying to think of someone who's been through a really traumatic thing and the grief is stopping them from engaging. Maybe I don't see them because the grief is stopping them from engaging. But most of the time when I come across it, people are comfortable.
And Peter, how do you grieve? What is it like to professionally see people die all the time? I think that's one of the things that perplexes people a bit when they ask me, I don't know how you do that. I don't know how I do it either, really. One of the ways is I don't work full time. That helps a lot. I'm fortunate that I can talk to my wife about it. We have different jobs, but we both come across people who are dying and we can talk about difficult things that we've been part of. I think, fortunately, we don't see things go terribly badly. We see things that are a mess, but when you clean them up, it feels really good. The ones that you think, a lot of people are more accepting and more comfortable with older people dying. So when there's younger people dying, it can be perceived as a bit more confronting, and it is in a way, but in other ways it's just the same. And I think it invalidates an older person's dying experience if you say that it's not as bad a thing as a younger person dying. But the younger person dying's, if they're like you, it's pretty confronting sometimes. Can really stay with you and probably stay in your mind a lot more.
Yeah, a little.
Is it that
there has been an ability for you to be part of that person's journey in a positive way that brings you some peace.
Yeah. I think that's what it is. I think it feels satisfying. That challenge of going into a stressful, tense situation with people feeling all sorts of different things and helping people resolve it in their mind and find some comfort in it and relieve the tension. It feels good when it works, and mostly I think we do a good job.
Well, I really admire the work you do because it's not something that really crosses your mind until, you start to become more exposed to death. And in my life, death had not been spoken about, if at all, and I hadn't really experienced anyone very close to me pass away. Or there it
there
is.
you go.
There it is.
Yep.
Close to me die.
The thing on euphemisms, you work out what to do yourself, but I think avoiding them is worthwhile. But don't feel bad about it. If you're going to keep using them, that's fine. I'm not going to be in your ear all the time going, oh, she said it again.
But I do think it is an area of life that we need to know more about, and I'm very grateful for you for joining me today to talk about a place that will most likely inevitably happen to all of us at some point in terms of whether we're caring for someone in our life that maybe is dying or that it's us ourselves. And
There'll be someone around in your orbit going through it.
Yep. So thank you very much for joining us.
Very welcome. So thanks for having me.
Pleasure. Is there anything else?
Joining me to unpack the last episode is Emma Keane. Emma Keane is a psychologist with over 16 years' experience across mental health and performance psychology, supporting adults with loss, trauma, anxiety, and the demands of performance. She is particularly passionate about working in the burnout, compassion fatigue, and vicarious trauma space to assist those in high-impact professions to sustain career longevity and well-being. She also works in sport and performance psychology with athletes, teams, and multi-passionate high performers, and delivers keynotes, workshops, and in-house training across both areas. She is also an EMDR accredited consultant with EMDRAA, EMDR Association Australia, that is, and holds additional qualifications in social work and nutrition, as well as writing books for children in her spare time. Whatever spare time there is for that. That's crazy. Welcome, Emma.
Thank you for having me.
Now, thank you so much for joining me today. We're unpacking Peter's episode. So tell me what you thought about that conversation.
I think the first thing that stood out to me, which was, I think listening to these, everything, you could pick out multiple things at once, right? So it's hard to pick out the most amazing thing. But I think the thing that kept coming back to me over and over again was the passion that he has for nursing, for that career, for that job. And he would be the person that you'd want there every step of the way. It was just so beautiful to listen to his experiences and the way he talked about his experiences and the people that he worked with. It was respectful. It was gorgeous. It was just really, really lovely.
I completely agree. He really downplays what he does or his impact, and what he does is remarkable. Everyone who works in that space, I think, must be an incredibly special human that has the ability to hold something that most people can't. And that's really admirable.
Yeah, I agree. I think it's one of the hardest things. I think, like you said, death is scary, grief is scary, loss is scary. So being able to sit in that space, I think, takes a special kind of person, and being able to sit in that space well. I think that fear of death, so that death is a really natural fear that he sees, but also the beauty in the way that he can make that a really gorgeous process. There was, I think, a statement he made around don't hurry. And I think that really stood out to me around, everything in that grief process, nothing needs to be hurried. So that respect along every step of the way, and that having time and space when you can, I think that was a huge take-home message for anyone who sits in this space.
In terms of cognition, listening back to our conversation, and it was making me think particularly about trauma and the inability to think clearly and logically. Is there any sort of advice that you can give for people, I don't know if it's about giving ourselves grace. I'm thinking more from the perspective of a supporter, of people supporting someone who may be dying, because it's really stressful. And that was one of the biggest things for me in our conversation, was how Peter was describing a colleague who was obviously very overwhelmed and was doing things that they wouldn't normally, even with their knowledge. And I think we can arm ourselves with a lot of information and education, but then when it really comes down to it, we don't have a huge amount of control actually over our logic in particular. So from a psychologist's perspective and what you've experienced and what you've seen, what's some information that you can share that might be helpful for people that are feeling very overwhelmed in those sort of situations?
I guess the first thing is that it is an overwhelming situation. Like, I think anything that challenges our view of that assumptive world, you know, that the world is generally good, that good things happen to good people, bad things happen to bad people. And then I think losing someone or sitting in that space of loss can shatter that view. So, of course, our entire systems are going to be completely overwhelmed, and that is normal and that is okay. And you should not expect to operate in any other way other than giving yourself that grace to be overwhelmed, to not be okay, to have those feelings, to be vulnerable in that space, to not have to hold it all together and be strong. Because I guess that's, and I don't know whether that comes through with culture or like the Australian culture of, you know, come on, keep going, like let's just keep going and dust yourself off and move on. But that I have to like be strong, I have to continue to push through, I have to just be okay. That pushing it off and keeping on pushing it off can sometimes lead to, you know, obviously catastrophic events afterwards. So that allowing yourself to not be okay, I think, is one of the most important things in that space.
And it's really normalising a lot of this space. Would you say grief, trauma, loss, mental health issues, mental illness, everything is all about normalising the shit, isn't it?
Yeah. Yeah.
To put it really simply.
Yeah. And having these conversations. So I think someone said to me the other day, why don't they teach this in school? Like, that'd be so great. Hear your life lessons around psychology and how to manage your mental health and your mind, and not all thoughts are true. And like, that would be great. And maybe we need a lesson in grief. We walk away from that, or we lean back from it, because biologically we're geared towards survival, right? So anything that threatens that, of course that's scary. Of course it is.
And what is going on in a brain that is experiencing a traumatic event?
Traumatic events are defined, you know, you could line 10 people up. I know I'm answering this a little bit roundabout, but you could line 10 people up who are experiencing the same event, and one person might say that that event is traumatizing and 9 people might say it's not, or the other way around. So when something becomes traumatic, it is because the whole system has become overwhelmed. So it has that inability to experience that as a normal everyday experience. It can't encode the experience. The whole system is in that, you know, fight or flight response, is in that hypervigilant state, is in that response where their entire system cannot cope with whatever is actually happening. And the meaning of that event, how we make meaning of that event, is what then defines it as traumatic.
And that can be based upon a really complex interplay of biological, psychological, social factors, history, attachment. The list goes on, doesn't it?
Yeah, definitely.
And you can never predict how you're going to respond in a situation that you might not have thought would be traumatic.
Yeah. And I think as professionals, I think we're talking about that story, I think we expect ourselves to know. You're like, I have the knowledge, I have the skills, I'm trying to prepare for this, I'm trying to put everything in place. But you can't logic your way out of an emotional experience.
I always go back to the trauma element often in a lot of these situations and in a lot of, I guess, everyday scenarios, because so many people don't understand or haven't taken the moment to consider that what they have experienced is a traumatic event. And I think if we normalise that more, there's still, when I do particularly mental health first aid and we talk a little bit about a trauma in one of the areas of the course, And it's always the perspective that the examples always come up about war, about military people, that they're the ones that have experienced trauma. But would you say in your experience it would be rare for someone to have not experienced a traumatic event once in their life?
I mean, clinically, yes. And I think when you're talking about that word, I think it's really important to actually normalise that it's definitely not just sitting in war-torn experience. There can be traumatic births, there can be traumatic deaths, there can be traumatic anything in your life. And I think that social media space where people go, oh, it's just traumatising, and then it takes away from our ability to name these things as trauma, because social media says, oh, it's traumatising, and it's become this kind of casual word that's thrown around. So we swing one way or the other. It's either, oh, we overuse it or we underuse it, and then it's invalidated in both spaces.
Yeah. It has been overused and I guess bastardized in a way that we have now dismissed the word and the weight of it has kind of been dissipated. And I find that with anticipatory grief, or when you are waiting for something to happen, you know someone is going to die. Like for me, our experience with Herb, that period of time where we didn't know what was happening, I'd say was just as traumatic and incredibly, incredibly hard to cope with. It was almost in comparison to the actual death and grief and loss. And I guess what I can observe in others that are anticipating a death, they dismiss what they're experiencing as because the person hasn't died yet. They think that that's going to be the worst part. And it is, but the anticipatory part, do you believe, is just as bad, if not in ways worse?
Yeah. There can be, I think at any point across a story, there could be a different point that is worse for so many different people. And I think within that waiting space and that limbo space, you're talking about a loss of control, a not knowing how bad it's going to be, a not knowing what it's going to look like, a often feeling of being trapped, like you can't escape this space but you can't process or grieve it or do anything with it. Like it's all way outside of your control, and that is traumatizing.
Yeah, definitely. That we really do think as humans we have so much more control than we actually have, don't we?
Yes. I think grief, loss threatens that a lot.
I loved the way Peter talked about language and the importance of it, and I've certainly learnt the importance of it, and I still made a gaffe at the end of the episode where I still talked about someone passing away, and he's like, it's so deeply ingrained in us, language. Can you share your thoughts about Peter's discussion of language?
Oh, I was so excited when I heard him talk about that. I was sitting there kind of cheering as I was listening to the episode going, yes, amazing, this is what we need. I think language, it's almost like an avoidance of the thing when you're using the language to then avoid of the problem. So it's like someone's passed away, someone has disappeared, someone is gone, and we're like, what does that mean? No, they've died. That is what's actually happened. And when we name it up, we can then validate it, we can help understand, we can create some finality around it. There is so much power in actually using the language to describe what's happened and to be able to then process that experience in an appropriate and validated way, and also internally validate it, right?
In terms of what's going on in our brain, I love asking psychologists these questions. Sorry, Emma, about language and the use of that and talking. It does activate a different part of our brain, say, than reading or writing, right?
Yes, it sure does.
And in these sorts of scenarios, you would say that every type of processing of that will eventually be helpful. As painful as it may be, writing about it, talking about it, thinking about it, if we kind of practice or work at it in different realms, will that help with our healing?
Processing the event? Yeah. I mean, that's the basis of my training, especially as an EMDR practitioner, is moving into the space of actually processing through whichever stages are happening for you and then getting out the other side and creating a new meaning. And I think that's what processing is to me, is creating either a different relationship with what's happened or a new meaning of what's happened. So then it is not that traumatizing or heavy or awful experience that sits with us. So the processing, I think, is crucial.
Oh, I really love that, framing it that you're creating a new meaning. That makes so much sense to me. And I like it even more than being like healed or healing, because it still, to me, new meaning implies continuity, because we often don't want to say, oh, like we're never healed, we're always healing, and we've never grieved, we're grieving.
Yes.
And we haven't moved on, we're moving forward. So I really love that, that you're creating new meaning by processing.
And there's a beautiful, I think it's Roger Solomon, works a lot in the grief area, and he talks about when he does his processing work is creating, you have a connection with the living, and then you also have a connection with them after they have died. So creating a new connection, which I think is a beautiful way of framing and a beautiful way of processing that grief.
Absolutely. A conversation today I was having about creating new memories with your baby that has never lived.
Yes.
So when people have died, you don't get the opportunity to make new memories, but you can continue or create new connections.
Yes.
And I love that you've just confirmed that, because it helps us look for things, doesn't it? It helps us look for symbols and signs and create, would you say it's like, it's not like romanticizing the world, but it's a softening. I don't quite know if that's the right term of the world around us, because when we've experienced a loss, everything just feels so harsh and different.
Yeah.
And a world we didn't know, and we don't like this new world.
No.
But I guess, is it looking for those connections can help us soften that new world?
I think that's a beautiful way of phrasing it. Yes.
And then when it comes to language, it can be really stressful, can't it, to get it right
Yes.
and to say the right thing. I mean, even I overthink, especially if I've found out someone has lost a baby or something's happened. I spiral and I worry about what I'm going to say. And I'm going to say the wrong thing. Am I going to say too much? Am I going to say too little? Like, I kind of panic a little bit.
Yes.
So what are some of your thoughts and recommendations around using language and not expecting to get it right every time?
Well, I think Peter talked about that, in that he acknowledged that he's a human and that we're going to make mistakes in this area and we're not always going to get it right. And I think if we've experienced grief and loss ourselves, it's so easy to look back and go, these were the terrible things that were said to me. I will never, ever say those things to other people. And we can go, amazing, those things go in the do not say ever basket. But then there's this realm of like, might be able to say, could be okay, I just want to help. And I think your intentions really matter in that space of, I am allowed to get it wrong. It's okay if you correct me, and being open to being corrected and making mistakes. You're a human, you're not going to get it right all the time. But that intent to be there and be present and just be there in a way that somebody else would like, and be open to what they need from you, not what you think they need.
And I think you can gain new respect, or a different level of respect, and maybe even a different level of connection. If you have made a mistake but you've learnt from it, you've grown from it, and you've grown together or learnt something together, I always try and encourage that to our waiters. Never pretend you know something. If you don't know the answer, go and find the answer. If you've made a mistake, let's fix it. And we've ended up having some customers that have been converted and are now customers for life. They loved what the outcome was, even though maybe we've made a huge mistake. I think you can let things flourish from there.
Yeah, we're humans. There is not a space where we're ever going to get it right, no matter how much knowledge or experience or training or anything you have in the area. There's going to be something you say sometime that doesn't land for somebody. Okay, own it and allow them to help you to say the thing that works for them. That's beautiful. That's allowed.
You are very experienced in the burnout space, and Peter acknowledged how fortunate he was to be able to work part-time. For people that aren't able to do that, or do that and still feel burnt out, do you have some general suggestions about what some people should be doing and what they should be perhaps keeping an eye out for within themselves?
I guess getting your foundations right is really important in this space. So making sure your sleep, your nutrition, your connections with other people are all there, and your physical movement, that activity, the ability to connect with those around you. If those at the bottom of the pyramid aren't working for you, then we need to really check in with those first, because we can't build skills on top of those. And often in this space, there are things that challenge our assumptive worlds working in this space around good things happen to good people, bad things happen to bad people. So it's looking out for, has my perspective of the world changed? Have I tried to take a step back from patients or people that I'm working with? Or have I really struggled to let the day go? Does the day now continue to bleed in? Is there not an edge? And then I think there's a flip side to this field that is absolutely phenomenal, and that's that vicarious resilience. And I think that ability to witness and look for specifically people's resilience is a gift that we should never take for granted in this field. And I think that really promotes longevity in some spaces.
How much would you say that hope has to come into this space and working in this space?
I think that's probably an opinion, so I'll flag that. But yeah, I think so much. I think if you don't hold hope, then it's hopelessness. And I think hopelessness is almost akin to powerlessness. And that in and of itself, sitting in a space and feeling powerless, that can feel traumatizing.
How difficult it is to work within this space when perhaps a family member or the person themselves who is dying has perceived some information with a level of varying accuracy, and that can really impact on the journey and then on kind of everything else around. Like for me, supporting a family member who was going through a diagnosis of cancer, and everything ended up being okay, but I went along to an appointment, and the information from the specialist and how it was received and how we discussed after, it was a completely different view, and the information, I had interpreted it a completely different way. What would be a helpful way of gently helping someone to understand the truth? You know, if someone's not accepting particularly maybe that they are dying or that their loved one is dying, are there ways that someone can support someone going through that in the most gentle of ways?
I think that's probably a very difficult question to answer in a simplistic term, but I think one of the things that's probably good to understand in that space is that if you are anxious, if your prefrontal cortex is offline, this part of your brain, that amygdala response, that us brain response, is amazing at responding in a really fast, quick way. Amazing. Great for running away from tigers. We love that part of our brain. Really, really bad at attending to details. Terrible. So if someone is sitting in a space and receiving information and they are terrified, their ability to attend to detail is significantly diminished. And I think that's something we as care providers should pay attention to and acknowledge, that this information might not actually be received. That information might need to be repeated. That information might need to be delivered in a very different way, maybe again and again in a different way, in a number of different settings across a number of different times, because that space of being terrified does not give us the ability to process and integrate information that's presented to us.
And I guess the space is fraught because if the information needs to come from a professional, they're time poor, they're not able to take the time to re-explain it or explain it in a different way or in a different form. We just have to accept what we're given at that time.
Which I think is why this kind of format is so critical, because again, if you have an understanding before you're going into this, you already have a background of information to draw upon before you're sitting in a space where you are terrified for a loved one or for yourself. And that, I mean, it's not going to change the situation, but it might change the way that you are able to sit in the situation. Potentially. It might not too, but it might.
Trying to lay a foundation, isn't it? Trying to have information as a tool and in the background of your mind.
Yes. And I think the more that we have, the more you are able to do with. I think sometimes half the work when you're sitting with someone who is grieving is actually saying it's okay. This is okay. These experiences, these emotions are okay. It is normal. It doesn't have a timeline. I think Kubler-Ross did an amazing job of giving us our stages of grief, but somewhere along the way that got mixed up. I hear so often people say, 12 months. But where did 12 months come from? Like, do we get a timeline and then we're not allowed to grieve anymore? Where did it come from? So I think there are so many different theories around grief actually out there, but this dominant one, and I don't know if it's hers that did the 12-month thing, it's just what we hear, but that space of going, there is a timeline on this. Like, no, there is not. There is not a timeline on any of it. You know, there's not a day where you go, I'm going to wake up tomorrow and then it will be done or it will be better.
Yes. And then we have that background information and we think that that's true and correct. And then we get to the 12 months, we're like, oh my God, why are we still feeling this way? And then we're harsh on ourselves again. We don't give ourselves grace. I mean, in most grief circles now, they will sort of say that early grief is 2 years.
Yep.
Early grief.
Yeah, that sounds pretty right. How do you put a timeline on loss? I think that's a bit arrogant, really, actually. Yeah, and everyone's experience is so individual. And I think we as humans, we like to put things in categories and boxes, and we like things in nice little boxes. It's great. We love it. But I think allowing the individuality is incredibly important because everyone's journey is going to look different. And I think that's what Peter talked about so beautifully, is allowing for that space and noticing that individuality and actually attending to and doing what the person in front of him needed, which again, for me, I was like, oh my goodness, this guy is the guy that you want.
I couldn't agree more. And with the normalizing it and making it normal, but for that person, because the next person that comes along, it will be different and their response will be different, but that's also normal. So yeah, I love your emphasis as well on that. It is normal and how human we are and the variance of being human. There is no average. There's no statistical average in this area, even though we think there should be.
Yes. Yeah. It makes it easier to treat if we can put it in a box, right?
Yes. And I know for me, I really wanted a date. I really wanted an idea of when the pain will end. And I think that informs a lot of our grieving and the process because we just want to know. Yeah. It's around that control, going back to that control again, isn't it? That we just want to know when will this stop hurting as much as it is and does. And unfortunately, that's so varied for each individual.
Yeah. Yes, it is.
Because it could potentially be a lifetime that they'll feel that pain, sadly.
Yes. The amount of love that you feel.
Yep.
And then we go, oh, can I just make it stop the pain now?
Yep.
I loved them all my life.
Yeah. And you mentioned with Kubler-Ross and now Mary Frances O'Connor has shifted. And I love the different realms and understanding that it's, time, space and closeness, I think it is. Time, space and closeness. So for people that we have loved for a lifetime, we've got the memory of them. We've got so much muscle memory of them being there, of conversations, of physical touch, of so many habits and rituals with this person. And then to unpick that can take a lifetime.
Oh, yes. Yes.
Yep.
And missing them, I don't think it disappears.
No. Well, thank you very much, Emma, for joining me today.
My pleasure. Thank you for having me.
Thank you. Thank you for listening. This podcast is dedicated to my son Herbert and to all the fellow grievers out there. I'm sorry that you're here. Be kind to others, but mostly to yourself. Before we wrap up, I'd just like to mention that whilst I do have a degree in behavioural science and have spent years educating myself and researching the topics of trauma and mental health, I'm not a licensed therapist, counsellor or psychologist. Everything I share here is based on personal experience and things I've learnt through education. This podcast is for informational or entertainment purposes only and isn't the substitute for professional advice. If you're struggling, please reach out to a GP or a qualified therapist. You're not alone and there is help available.